Even you're muted.
Guys, we're going to give it a couple minutes before we get started here. It's like 70, 100, 120, 130, 150. Okay, people are going to keep filing in, so we'll give it a couple minutes. We're going to start here probably at 7:05. It's 7:01, so get a glass of water, go to the bathroom, do whatever you need to do, and then we'll get started shortly here. Just give it a couple minutes. Okay, we'll just give it another couple minutes, everybody, and I'll start with introductions and we will get started. Okay, I'm going to go ahead and start off with introductions, and then I'll let the two gentlemen of the hour take over. So first and foremost, everybody, thank you very much for hopping on. We appreciate your time, especially on a Monday. We know it's a busy and crazy day, and it's a lot for you guys to take some time after hours. We're going to make sure it's definitely worth your time, though, and that's the most important thing is really turning up the value on our time, especially when it applies to biologics. So my name is Beeben Russell. I own Platinum Biologics, and Platinum Biologics is sponsoring this webinar. We are not directly hosting it. The host of this webinar is actually, and I always get this wrong, so let me just double check this. Is actually, we have, for those of you that don't know, that are showing up for the first time, we have the Institute of Regenerative Education. This is the largest and fastest growing private Facebook group, and it's semi-private, right? Anyone can request to join. You just have to fill out your 3 answers. But we actually have the largest and fastest growing biologics community where doctors are sharing protocols, bouncing ideas off each other. What we've done is we've been able to remove the siloing that we see doctors get stuck in so often in specifically in biologics, but just in practice of medicine, where they can be amongst their peers really challenging new outcomes, new perspectives, and new financial and economics in their practice. And that's what tonight's going to bring. This specifically tonight is pain to profits. We're going to be spending a lot of time on pain and pain doctors and biologics. However, we're going to make sure that there's a bit for everybody. We open this up to everybody that's wanting to use biologics. There's going to be a mass amount of clinical pearls, but really one thing I want to acknowledge here is that we've seen PRP, we've seen bone marrow, we've seen that throughout the industry as becoming the mainstream biologic. Another thing that we know and we have seen is that it absolutely has its limitations. What we've seen both through research, but also through really outcomes, and many of you that are challenging the status quo of what's possible with biologics in your own practice, we're seeing birth tissue allografts and birth tissue products become ever more popular. We're even seeing stateside now. We're going to talk about states and what's happening to pain, PI, what's happening with biologics in different states. We saw Utah legalize. I always say Dr. Evil, air quotes, legalize, because it wasn't illegal. But what the state did is it reminded doctors, wake up, you have the right to practice medicine. You have the right to use these biologics. There's no indications or clearances for use of PRP, just a harvest. And I know Dr. Martin will touch on this, but what we're seeing is doctors realizing, well, wait a second, not everything has to be approved, right? So my point in all saying this is that birth tissue allograft, we are very happy, and this is a milestone, I think, for allogeneic biologics, where medical doctors, pain, PAs, NPs, integrated facilities are all coming together and seeing the most progressive thing in cash pay, and it's biologics, while we're also kind of getting our asses handed to us when it comes to the economics of insurance. And people are wondering, where the hell is the light at the tunnel? Well, ladies and gentlemen, I want to offer you a significant light at the end of the tunnel for many that have happened to our customers and other people alike that have taken the steps and even taken words from Dr. Martin. So with that, let me do the first introduction here, and then I'm going to turn it over to Dr. Martin. For those of you, Dr. Martin, I'll let you do your own introduction. I know you like hopping into that, but we also have a co-star and guest, Dr. Chun. Dr. Chun is actually double board certified in anesthesiology with a subspecialty certification in pain. Dr. Chun has probably, I would say, in North Texas, if not the whole state, one of the biggest, largest, most successful pain practices, heavily in PI. And someone of his caliber is looking at cash biologics. So I'll go ahead and turn that on over. Gentlemen, we appreciate both of you. Thank you for having us and showing up for everybody. Dr. Martin, take it away.
So first and foremost, I want to thank everybody for attending. For any of you that don't know, I'm Dr. Scott Martin. I'm an interventional pain doctor by training. Right now, I'm in Southern California. I just left a conference that we gave in Cancun, Mexico, to about 34 doctors there. It was a 2-day conference. My flight got canceled, and then it got delayed and almost canceled again. And so typically I would have done this in my office, but we're actually in the clubhouse where our little beach house is in Newport Beach, and they were kind enough to let me use this evening. I'm joined by Dr. Chun, a colleague and really just a rock star in the pain medicine community. He's kind of what every real pain doctor, including me, aspires to be. He's got just a gorgeous facility. He has a wonderful staff, works extremely hard, 5-6 days in the office, really has a wonderful team amassed. And he's kind of figured out what most of us didn't, which is really how to develop a big, robust clinical practice, balancing insurance and personal injury. And he and I met when he decided to dip a toe in biologics. And I'll let Dr. Chun introduce himself. But it's simply an honor always to lecture and speak and to share the stage here with Dr. Chun. Dr. Chun, do you want to pop in and say a few words?
Hello, thank you for the nice introduction, Dr. Martin. Excited to be a part of this today and definitely integrated biologics into not only the cash part of our business, but also the PI portion as well. I think there's application in both, and really want this to be a big part of the practice going future, because I do believe it's the future of medicine. We've been injecting steroids for decades now, and I think there's a better way.
I could not agree more. And so we're going to go through a number of different paradigms. The last time I gave one of these lectures, the whiteboard fell and it hit me in the head. That's entirely possible that'll happen again today. So we're going to start with just a story. All right. And I like to start with stories because it sets the mood. Now, the story is actually about me. In 2012, I was fairly convinced I was King Kong. I was at what I considered the top of my game. I was practicing in Southern California. I was doing very well. I was living in a house on a cliff overlooking the ocean, not a lot dissimilar from this. I was driving a vintage Jaguar that I'd spent 2 years taking from bare metal. It was a 1969 Jaguar XKE. And I was working conservatively 6, sometimes 7 days a week in a local hospital and in my own office. But I was also dying. At that point in time, I had conservatively $57,000 a month in overhead. That included my malpractice, $57,000 a month. What it did not include is it did not include my mortgage, which was $14,000 a month. It didn't include car payments and groceries, sending kids to school, my wife's car, our third car. The point of this is there are many doctors who are building very big, robust medical practices. And outside looking in, their practice may seem very, very impressive. And they may be driving a very nice car, and they may wear really nice stuff. Does that necessarily mean that they're successful in their practice? Moreover, what does success look like in a medical practice? We're going to get into a lot of this. But where I want to start is the ultimate paradox in medicine. Right now, any of you who have practiced medicine for about the past 10 years have endured the very first paradox in medicine. And the first paradox in medicine, and we will set one against the other here, was pain is the fifth vital sign. Now, I don't know if any of you understood that, lived through that, but essentially, if a patient had a pain score that was greater than 6, we had a medical legal responsibility to treat those patients. Medical legal responsibility. And if you didn't treat that patient, you could get sued. Now, this all started actually right here in California. There was an oncology patient, and that oncology patient had an oncologist who was uncomfortable writing narcotics. And that patient was given Tylenol extra strength for lymphoma. And that patient sued his medical doctor because he failed to treat his pain. And that doctor not only lost that case, but had his license put on probation, and he ended up quitting the practice of medicine. All true story. What that did was it set medical legal precedent that, as far as I'm concerned, destroyed the practice of pain medicine. Why did it destroy the practice of pain medicine? Well, it did 2 things. Number one, it set a precedent for the use of narcotics. At the height of the narcotic epidemic, we were losing conservatively 40 to 50,000 lives a year. That was before synthetic fentanyl. Now, almost no doctors are prescribing narcotics, but today we are losing close to 150,000 patients a year to synthetic heroin and fentanyl being brought in across the southern border. Many more patients are dying, but they're not dying from prescription narcotics. What was the second precedent? If this was the first precedent, what was the second? So we had essentially an epidemic of narcotics. What else did we have? Well, we had a precedent for procedures. What do I mean by we had a precedent for procedures? Well, it was a heyday for any pain doctor. Spinal cord stimulators, morphine pumps, facet blocks, medial branch blocks, radiofrequency ablations. You name it, every pain doctor essentially had carte blanche because you had an indication to treat and you had pain as a fifth vital sign. What did this do? This tremendous overprescribing of narcotics and this tremendous overindulgence in procedures. Well, it did two things. Number one, it destroyed pain doctors. Meaning the narcotic epidemic was laid at the feet of pain doctors, not by primary doctors who put their patients on 120 milligrams of OxyContin twice a day for fibromyalgia. No, the pain doctor that the primary doctor referred the patient to after he got uncomfortable with the massive doses. Now, the primary doctor went to the Purdue lectures and got all the wonderful steak dinners and all of the bagels and the donuts and the free coffee. But when he got a little uncomfortable, that's when he referred it to the pain doctor. I don't know how many doctors got investigated. I was one of them. I can tell you that personally. Here in the state of California, the medical board took narcotic prescribing guidelines that came out in 2016 and applied them retroactively 10 years previously to charts from 2006 and 2007. That was my life, right? And so because I was a very busy pain doctor and I wrote a lot of meds because a third of my patients were narcotic detox, a third were end-stage cancer patients, and a third were trauma, I wrote a lot of narcotics. And so I got to do 4 years of probation because when they looked at my charts, they didn't feel that my charts in 2006 met with the recommendations set forth in 2016. There's no defense for that, right? Not enough legal counsel in the world could have gotten me off that. So I got to do 4 years of probation. So did hundreds of pain doctors that were my colleagues. All of us had this narcotic epidemic laid at our feet. What else happened? Well, because we were doing tons and tons and tons of procedures, Medicare decided, hey, let's dramatically slash reimbursement for procedures. Now, unless you're a pain doctor, you won't know how bad it's gotten. But at one point in time, you could do a spinal cord stimulator trial, and Medicare would pay you $4,950 to do that trial in your office. Now you can do that trial in the surgery center, and if you get paid $700 or $800, that's a lot. Where the real rubber meets the road, though, is where doctors make most of their money, which is in things like medial branch blocks and facet blocks and radiofrequency ablations. Those CPT codes have fallen over 50% from 10 years ago. 50% reduction in fee. That's substantial. There are some nuanced fees that have gone up, but the bread and butter things that doctors do in their offices all day, every day, those codes have been slashed dramatically. Radiofrequency ablation, a darling of the pain community, no longer reimbursed by Medicare for sacroiliac joints. Very soon, and potentially starting January 2026, radiofrequency ablation for the lumbar facet joints will be taken off formulary, meaning that Medicare will no longer reimburse for lumbar RFA. Now, The plan is they're going to roll it out in certain MACs and see how it goes. There are 12 Medicare associated contractors in the United States that regionally determine fee structures for the physicians in their states. And so it may not hit every MAC at once, but you betcha it's going to happen to a few. Now, if this wasn't bad enough, and this is bad, believe me, this is bad. Could it get worse? Does it get worse? Actually, it does. So we're simply talking about pain doctors in general, but there are plenty of doctors that subspecialized in pain who weren't fellowship trained in pain medicine. They're primary doctors who are very, very adept at treating pain patients. They're chiropractors, very adept at treating pain patients who had doctors in their office seeing pain patients. Tons and tons of naturopaths were wonderful in managing pain patients. So how did we do with all that? Did we do really, really well with our patients? Well, as it turns out, we did not. Now, when you look at kind of the quiver of a pain doctor, the quiver of a pain doctor contains only a few arrows, not a whole lot, unfortunately. Let's get into those arrows. So we're a pain doctor, and our RX pad, our prescription pad, is one set of arrows, and our procedure, we're going to call it CPT code, is kind of our other script pad, quiver of arrows to treat pain patients. From a prescription standpoint, we have oral steroids, we have narcotics, we have NSAIDs, and then we have kind of the extra stuff, right? We have membrane stabilizing drugs. We have all of our antidepressants, right? And then we just have kind of this mixed bag of everything else, right? We had topicals, lots of doctors got lots of problems with topicals. Some even went to jail. But the big three for pain doctors are right here. Now, what you may not know is that those three medications, oral steroids, narcotics, and NSAIDs, have substantial peer-reviewed literature to demonstrate that they increase all-cause mortality. All-cause mortality. Now, there's no question that using narcotics for longer than a month, actually in some studies, only after 2 weeks, will patients develop physical dependence. Physically dependent after 2 weeks. That means about half of every surgery where a patient stays in the hospital for over 2 weeks and gets narcotics, they will suffer physical dependence, meaning when the narcotics are stopped, they will have withdrawal. But the problem comes in when patients are on narcotics for over 6 months. And over 6 months, there is predictable mortality associated with the long-term use of narcotics. That's a problem. What about oral steroids? British Medical Journal, 2017. Fabulous article. Looking at the chronic use of steroids and what they were able to show in rheumatoid arthritis patients, and please make no mistake, pain doctors see tons of rheumatoid arthritis patients. Your rheumatoid patients may be seeing rheumatologists, but after the rheumatologist stopped getting paid to do IV infusions and stopped getting paid to do their IVIG and whatever else, and there are no great drug dinners for the DMARDs anymore, and there's only a few biologics that work, what do? Well, they send them to the pain doctor to write pain meds. Or they start the patient on narcotics and then get uncomfortable refilling them and refer the patient to the pain doctor. And now it's our problem to manage. Well, what about the oral steroids that they put these patients on? British Medical Journal, 2017. Patients on oral prednisone greater than 15 milligrams a day for longer than 6 months, a doubling of mortality. Doubling of mortality. I didn't stutter. That's terrible. But how many patients do you have that are on 30, 40, 50 milligrams of prednisone a day and have been on it for years? Their mortality is higher. Okay. What about NSAIDs? NSAIDs really don't get the attention they should. Conservative estimates on NSAIDs are that somewhere between 16,000 and 150,000 patients die a year from complications of NSAIDs. Now, that is a really large swing, really large. So why isn't it buttoned up? Why isn't it specific? Well, who's one of the largest manufacturers of NSAIDs? Bayer, who sued me, yours truly, personally in 2017 for creating an NSAID alternative. What do I think the numbers are for NSAID-related deaths? Kidney disease, heart disease, GI bleed, strokes. I think it's probably closer to 200 or 250,000 patients a year with associated NSAID-related mortality. There's a wonderful study that looked at patients that had heart attacks who were on NSAIDs, prescription NSAIDs. And those patients that had heart attacks, over 45% of them were on prescription NSAIDs. And if they stayed on the prescription NSAIDs post heart attack, there was a tremendous increase in mortality, well over 50% increase in mortality if they were, if they were left on the prescription NSAID. So we're using drugs that are killing patients or increasing mortality. This isn't a good look for all of us pain doctors. And we've been doing this for years. Oral steroids, narcotics, NSAIDs, these were our bread and butter. Okay, so it's got to get better. It's got to get rosier, right? All right, then we did a lot better with procedures, right? We just did much better. Well, did we? What's the number one procedural product used by pain doctors? It's steroid. Again, meaning cortisone. I gave tons and tons and tons of cortisone injections. Now, do we use anything else? Sure we do, right? Some folks use a concentrated dextrose and they'll do prolotherapy, right? Not very common anymore because it doesn't reimburse, right? What else do we use other than steroids? We use lidocaine or Marcaine, but these are really for diagnostic injections, not super common. What else do we inject? Well, we inject some hyaluronic acid, right? And some pain doctors use PRP, some of them use PRFM. And very, very few use BMAC, bone marrow aspirate concentrate. This is delving into biologics. We're not going to talk about that. We're going to talk about the King Kong. We're going to talk about the drug that we use the most. Well, the majority of pain doctors use one specific type of cortisone. It's called aqueous dexamethasone. And we use aqueous dexamethasone because any procedures in the spine using a particulate product like depomedrol have over the years proven to be catastrophic. Specifically, patients would end up getting an emboli from the precipitate of the depomedrol, and they would get showering of this precipitate that would end up causing usually paralysis, ischemic injuries to the spinal cord. This has happened with interlaminar epidurals. It's even happened with caudal epidurals, which I think is amazing. Transforaminals, of course. Depomedrol If you use that in the cervical spine and you do a cervical transforaminal and the patient dies, or the patient goes to a hospital with a complication, stroke, infarct, and you used a particulate steroid in the cervical spine as a pain doctor because of the overwhelming literature documenting the problems with that, it is immediate revocation of license and usually jail if the patient dies. Now, if that wasn't bad enough, is there any literature that substantiates that steroids may not be so hot? Well, as a matter of fact, JAMA published a wonderful article all the way back in 2017. And in 2017, they showed that giving steroid injections in a joint quarterly for more than 2 years dramatically increased the risk for joint replacement. Now, this is well before probably one of the most famous articles came out in Radiology 2020 that demonstrated that the serial application of steroids didn't actually improve joints. It actually caused serial worsening of the joint, dramatic worsening of the joint. But hell, we had literature 3 years prior in JAMA showing that these patients were getting really, really high rates of joint replacement. Is that a problem? Well, as a matter of fact, it is. We take the standard OA knee patient and we give them a bunch of cortisone injections and they don't work. And they end up having a joint replacement. Joint replacement. Is there mortality associated with joint replacements? As a matter of fact, there is. Specifically in load-bearing joints, hips, knees. Revision joint replacement in load-bearing joints actually has a substantial increased risk of mortality. Substantial. Now, are our joint replacements lasting 15, 20 years? I literally had a conversation with a patient today on my drive from LA to here. That patient is 70 years old, very healthy, ran all the way up until COVID, stopped running over COVID and started to experience more pain. She's had 11 cortisone injections in her knee. She has what her orthopedic surgeon has called bone-on-bone arthritis. She's had 2 PRP injections. And she said, well, Dr. Martin, she's like, I just want your opinion. If I get a joint replacement, will I die with that joint replacement? And I had to be very blunt and tell her it's unlikely. At 70, your life expectancy as a female is actually 87, which means that best case scenario joint replacements today aren't lasting 15, 20 years. They're lasting between 7 and 12. So that puts you at about 78, 79 to 82. You may end up having a revision joint replacement in your lifetime, which increases your mortality. And if you don't know that, that's actually your fault because you just haven't read the literature. If you have a 70-year-old patient and you talk them into a joint replacement as an orthopedic surgeon, and you haven't told them that there's a likelihood that they'll have a revision joint replacement before they die at 87, and that there is some increase in mortality with that joint replacement, I don't think that's painting the clearest picture. It's kind of painting around the edges, but it's not really filling in the middle. I'm not an orthopedic surgeon, I'm a needle jockey. But irrespective, I think it's important to let patients know what can and may happen. Now, there's a bell-shaped curve with all joint replacement. She may die with that joint replacement at 92. But what is the likelihood of that post-COVID with patients now sicker than they've ever been? Pretty unlikely. Pretty unlikely. Now, we've talked quite a lot about what pain doctors have done in the past. right? And this has been my profession for 25 years. I've been a pain doctor for 25 years. I don't practice pain the same way as I did. I am not the pain doctor that Dr. Chun is. Dr. Chun is a pain doctor's pain doctor. Surgery center, he's in surgery on a regular basis. I don't have a C-arm. I haven't done that since 2020. But I address pain a very different way. Now we're going to talk about how I do that in my practice. And we're going to kind of blend a few things. I'm going to try to talk quickly because I don't want to keep you here for 10 hours, even though I could talk for 10 hours, because there are a lot of interesting topics. And I think all of them bear mention, at least in some respect, because all of you are interested in the very same thing. You're interested in taking your pain patients and getting much better outcomes. And you're in a marketplace where patients are being told all sorts of things from all sorts of folks, right? So let's get into the field of biologics. And let's be a little bit specific for any of you who may not have seen any of my videos in the past. When we're talking about the field of biologics, we are talking about human cell and tissue products. We're not talking about some voodoo paradigm. We're talking about human cell and tissue products, which means that all of these products are umbilical cord tissue coming from full-term consenting females, processed in AATB labs, right? All of it screened for COVID, What this is not fetal tissue from aborted fetuses. And this sets up our dichotomy. We've got all sorts of clinics in Panama, Costa Rica, Mexico, and all of those clinics sell pluripotent stem cells. You'll notice I didn't put stem cell up here. I said human cell and tissue. I did not write stem cell. And then you've got, we'll just call it platinum, which is the gold standard here in the US and in Mexico. They are using differentiated mesenchymal stem cells, and specifically from those cells, Wharton's jelly and exosomes. Now, before we get into Wharton's jelly and exosomes, I want to make something clear. For all of you who don't know, we cloned a sheep many moons ago. I believe it was 2010 or 2012. That sheep's name was Dolly. I called her Dory once before in a video, and I apologize. She wasn't in Finding Nemo. Dolly was cloned using pluripotent stem cells. Now, the problem with some of these clinics like CPI and others overseas, when they use pluripotent stem cells from aborted fetal tissue, those cells can turn into anything in the human body, absolutely anything. They can also turn into cancer. And so what's our cautionary tale with Dolly? Well, Dolly was cloned using pluripotent stem cells. And you say, well, Dr. Martin, that's fabulous. We cloned a sheep. A sheep, we just made a sheep. There was no sheep, and now we got a sheep. That's awesome. Well, that sheep unfortunately died of metastatic cancer about the age of 5. So we cloned a sheep, but the sheep died. So now we got dead sheep. All right. Not so great, right? But that isn't really the sticking point. The sticking point was that Dolly had 5 little baby sheep. I don't even know how to do a little sheep here, but I don't know. Anyway, 1, 2, 3, 4, 5. All 5 of those baby sheep died of metastatic cancer before a year of life. Let's just say that was the 5 nails in the coffin of very public cloning exercises. Many companies that were going to cash in on cloning suddenly weren't so excited about cloning humans anymore using pluripotent stem cells. Now, what else is the problem with some of these clinics that are using these really high concentration cells? Well, there's nobody policing what they do. When you use concentrated pluripotent stem cells, concentrated pluripotent stem cells can aggregate or coalesce. And if you just happen to be on high dose testosterone, or you just happen to have pulmonary fibrosis, or you just happen to have myelodysplastic syndrome, or anything that's going to cause you to be thrombogenic, and I slam a whole bunch of cells in you, you run the risk of having a heart attack, a stroke, or worse, a saddle embolus in your lungs. And there are plenty of patients in Mexico who have succumbed to this. Because again, what's happening over there is happening without discretion. And because, patients have kind of done okay on it, think, well, it's great for everybody. Well, no, it's not. You actually need to know what you're doing. If you're not screening patients and you're just telling them, hey, look, you're going to be cured of your pulmonary fibrosis because we're going to give you some pluripotent stem cells, you're going to be cured. Unfortunately, there's a patient out there who had pulmonary fibrosis, who got a bunch of cells. She doesn't have pulmonary fibrosis anymore. She's also not alive anymore. So she doesn't have to suffer her disease, but I don't think the way they went about it was exactly the way you would want your patients to go about it. This is dangerous. And it's dangerous because the cells they're using are not made in the USA under FDA guidance by AATB standards. Lord only knows how they're being screened, right? Are they using COVID tissue, non-COVID tissue? Do they have a bunch of spike proteins, which are also thrombogenic? I don't know. And you know what? I bet they don't either. That's a problem. So that aside, let's get into what we are actually talking about. All right. And I'm not going to dive aggressively into anatomy, physiology, but some of it is important, terribly important when we're talking about trying to get patients better. Because let's face it, is it a stem cell that gets a patient better? It's not. It's the practice of medicine that gets a patient better. Why are we using human cell and tissue products? We talked initially about a paradox in medicine, the first paradox that destroyed many patients' lives and many doctors' lives, in particular in pain medicine. And that paradox was the 5th vital sign. Well, I'll give you the second paradox. And the second paradox is very simple. We're not trying to cure anyone. We're practicing medicine, number one. Number two, We're trying to prevent the progression of disease. And I'm going to speak in detail about this because I think it is underemphasized. If you are talking to patients about stem cells, your patient hears in their ear, I'm going to be cured. Oh, doctor, you're going to give me stem cells. You're so fabulous. You're marvelous. You're going to cure me. That's not what's going to happen. And I'm going to explain why. So if we take mom, here's mom, right? She's got a big belly, right? And here's her little baby, right? She has an umbilical cord. That umbilical cord, on average, is 28 centimeters long. That umbilical cord has an epithelial layer, right? Has 3 blood vessels, all right? And then has a gelatinous-like substance called Wharton's jelly. Now, Wharton's jelly was identified by Dr. Wharton in 1950. Now, what is unique about Wharton's jelly? What's unique about Wharton's jelly is a couple things. As all of you are sitting there, and you're looking at this snake-like Wharton's jelly thing, I also want you to picture a knee joint. Femur, tibia, fibula, medial meniscus, lateral meniscus, ACL, PCL, LCL, MCL attached to the medial meniscus. I also want you to picture the intervertebral disc, nucleus pulposus, annulus fibrosus, ring-shaped lamellae laid down in layers, the annulus fibrosus, and again, a gelatinous-like substance, the nucleus pulposus. Now, the reason I tie all of these together is so that you understand how special this substance is. Right now, as all of you are sitting watching this, maybe drinking coffee like me, or maybe having a cocktail, I don't know. I want you to think back and reflect on the last 90 days of your life. And I want you to ask yourself, how much type 2 collagen have I had? You may think to yourself, I don't know what the heck you're talking about, right? How is that even important or relevant? What does that have to do with any of this? It seems very left field, Dr. Martin. I'm a little left field, right? Anyway, well, type 2 collagen just happens to make up 90% of the nucleus pulposus. 90% of the intervertebral disc center that provides cushioning for all of your vertebral bodies, from the top of your spine to the base. Type 2 collagen also covers the articular surface of every joint in the human body. It covers the articular surface of the femur and the tibial plateau. It's in SI joints, it's in thumb joints, it's in facet joints, hip joints, shoulder joints, elbow joints, wrist, ankle joints. The problem is that type 2 collagen is not synthesized by our body. We don't make it. Be like, well, for sure, we definitely make type 2 collagen. There's no way we don't. Okay. Platelet-rich plasma has what growth factor complex? Type 1 collagen. Bone marrow aspirate concentrate has what type of growth factor complex? Type 1 collagen. Stromovascular fat has what growth factor complex? Type 1 collagen. We're going to get into the randomized controlled trials saying that PRP and BMAC actually have type 2 collagen in a second. But physiologically, the only growth factor that's in your blood right now is fibrin, which is type 1 collagen. Your bones, the majority of your bones are made up of type 1 collagen. The fibrin, the structure that holds fat globules together, not the fat themselves, the matrix that holds fat globules together is also type 1 collagen. And that sets up a little bit of a problem, right? Because blood, bone, fat are the source for all of the stem cells in our own body. And none of them contain type 2 collagen. Blood, bone, and fat are the source for all stem cells in our body, and none of them contain type 2 collagen. This is why we get degenerative joint disease and degenerative disc disease, because our body doesn't synthesize type 2 collagen. We don't make it. And if you thought for even a second about what you've eaten in the past 90 days, you don't consume type 2 collagen either, unless you really like bone marrow or bone broth and have it on a regular basis. The joint here, the soft tissue structures, the medial meniscus, lateral meniscus, ACL, PCL, lateral collateral, medial collateral are actually type 1 and type 3 collagen. As a matter of fact, so is the annulus fibrosus. Makes sense that they're all the same types of collagen because phylogenetically they started from the same ectoderm. Why is Wharton's jelly the hottest thing going? Well, Wharton's jelly contains type 1 collagen, type 2 collagen, and type 3 collagen. It also contains quite a lot of hyaluronic acid. That's pretty sexy. That is pretty sexy. Most of you may have used amniotic fluid. Amniotic fluid was very, very popular for a while. Podiatrists loved amniotic fluid. Why? Because amniotic fluid had a lot of hyaluronic acid in it. And hyaluronic acid has a natural tendency to downregulate inflammation. That's great. Wharton's jelly has almost 100 times more concentrated hyaluronic acid than amniotic fluid. 100 times more potent. But Wharton's jelly only exists in nature in the umbilical cord of animals, mammals in particular. So unless you're pregnant or unless you just got an injection recently, you don't have any Wharton's jelly in your body. But if you had a patient with bad arthritis of the knee and you had to choose between something like PRP or BMAC or stromovascular fat or something like Wharton's jelly just off the cuff, what makes more sense? Well, without question, the one that's actually got type 1, type 2, and type 3 collagen. Just blatantly obvious. Now let's dig in a little bit, because this is actually where I really enjoy it. All right. Now, I'm not loved by many doctors, not at all. And the reason I'm not loved by many doctors, and some of them own PRP companies and bone marrow aspirate companies, is because I have this persnickety little tendency to actually read the literature. I just, If somebody tells me something often enough, it just hurts my brain. And if somebody yells at me over and over and over again, well, this is the way it is. This is the way it is. I pretty much just assume that it's not. The foundational, well, let's just start with some paradigms, right? Platelet-rich plasma, PRFM, even A2M, BMAC, and SVF. First, make a little chart. And we'll put Wharton's jelly down here. Okay, last place, right? First, is it inflammatory or non-inflammatory? Seems kind of important, right? Got a patient that walks in, grade 3, grade 4 arthritis of the knee. Knee swells on them, in particular when they play pickleball. Wake up in the morning and every now and then it's swollen. The swelling gets a little bit better during the course of the day, but if they get active, it swells again. Ideally, if that patient comes to your office and they want something done, is it a super good idea to do something that's going to cause more inflammation? Probably not. Probably not. Well, PRP, PRF, PRM, are they inflammatory or do they downregulate inflammation? Well, as a matter of fact, they cause inflammation. We have all heard the term pro-inflammatory response. Okay, what does that mean? Specifically, what it means is that these products stimulate an M1 macrophage response that stimulates microRNA that then does three things. Number one, it upregulates IL-1 beta. Number two, it upregulates IL-6. And number three, it upregulates TNF alpha. That trio causes inflammation. Now, before you say, well, Dr. Martin, yeah, of course it causes some inflammation, but that's good, right? We want inflammation in the joint. That's a great thing. We get a little inflammation. The body sends those lovely stem cells to the knee joint by way of chemotaxis. And then we have that paracrine response with some cell-to-cell signaling, and then the magic happens. Then we get type 1, type 2, and type 3 collagen just using PRP, right? 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 Well, no. No, that's not actually what happens at all. As a matter of fact, you just cause a bunch of inflammation because we're not in 2019 anymore. We're in 2020. And the majority of your patients have either had COVID or been COVID vaccinated or been COVID vaccinated and got boosters or have chronic Lyme disease, chronic Epstein-Barr. They've got autoimmune issues. They have long COVID, chronic Lyme disease, chronic mold toxicity. All of these issues are making your patients less healthy today than they were in 2019. And what that means is their humoral response, their ability to fight off infection, is dramatically blunted compared to what it was in 2019, pre-COVID. So if I cause inflammation in a joint by putting in something that's pro-inflammatory, like PRP or PRFM or A2M, I'm going to get a predictable effusion. Predictable. That predictable effusion should last 3 to 5 days. What if it lasts longer? 30% of your patients are diabetic or pre-diabetic. Blood is a wonderful nidus for infection. If your patient's got a 5-day-old effusion and they're diabetic, I hope you're not going on vacation this summer, because that patient either has a persistent diffusion or they have a septic joint. And if you don't get eyes on that, you don't know the difference. Okay. What about BMAC? Bone marrow aspirate concentrate. Is this also pro-inflammatory? Well, unfortunately, yes, it is. Stromovascular fat, is that pro-inflammatory? Well, yes, it is. What about Wharton's jelly? Wharton's jelly is immune privileged, meaning it down-regulates inflammation. Okay, doc, give me the juice. How? Why? Well, one of the constituents in Wharton's jelly are exosomes. And those exosomes from Wharton's jelly don't work by way of an M1 macrophage response. They work by way of an M2 macrophage response, which also activates microRNA to do what? Down regulate IL-1 beta, up regulate ARG1, and up regulate IL-10. This has a net anti-inflammatory response. That's a good thing. Does it get better? Actually, it does. It gets better. Okay, we looked at inflammation. What about stem cells? Let's look at stem cells, right? This is a stem cell lecture, right? Don't we all love stem cells? Oh man, we love stem cells, right? How many stem cells are in PRP? How many stem cells are in PRP? Yay, PRP! How many differentiated mesenchymal stem cells are in PRP? Oh, none, 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 none. We've known since like 2017. None, zero. So if you're doing regenerative medicine, are there any stem cells in PRP? No, there's none. That's not great. What about BMAC? Are there any stem cells in BMAC? Technically, there are some differentiated mesenchymal stem cells. I feel a little bit like Elizabeth Warren here because the amount of stem cells in BMAC is 0.001% per draw, right? Kind of just a bit of Comanche or whatever she said she was, right? But literally 0.001%. That is not a lot. SVF and Wharton's jelly are the only ones that actually have mesenchymal stem cells. The difference being that SVF is inflammatory and the growth factor complex is just type 1. Wharton's jelly is immune privileged and has type 1, type 2, and type 3 collagen growth factors. Now, we've talked quite a lot about the differences. And I know Dr. Chun is either falling asleep on me right now or is like, hey, bud, you know, I didn't jump in here for my health. So I want to apply this in common practice because all of this theory is great. But if you can't apply it in common practice, how do you use it in your clinic? And moreover, how do you get paid to use it in your clinic? And that's what we're going to do right now. So, Dr. Chun, while I erase this, would you like to introduce our first case? Even is Dr. Chun there?
I'm here.
Awesome. Dr. Chun, would you like to introduce our first case?
Sure, I would love to.
Outstanding. Hit me.
So we got a 26-year-old Hispanic male. He was actually involved in a motor vehicle accident, had an acute disc herniation at L5S1, 4 millimeters, causing a little bit of foraminal stenosis, had some radiculopathy. However, he had 2 transforaminal ESIs and continued to have discogenic and some radicular pain. Saw our neurosurgeon, was deemed not a surgical candidate, but he's 26. I don't want to put this guy through a spinal cord stimulator trial and for possible implant at 26. So I know what I did, but I want to hear what you would do, Dr. Martin, in this situation.
So let's talk about it. What did you do?
So I actually talked to him about regenerative medicine and decided that we were going to use some exosomes using the same transforaminal approach to help with that inflammation.
Sexy. So let's get into a little pathology. All right. What Dr. Chun's not telling all of you is he's actually a damn good clinician. I've seen him with patients. I've seen him walk through a physical examination. Even though he's an anesthesiologist, he's actually very gifted when it comes to a musculoskeletal examination. When you have a patient with discogenic low back pain, and all of you in your medical practices have patients with discogenic low back pain, it is terribly important to discern whether that discogenic low back pain is radicular and causing a radiculopathy or a radiculitis. Because treating one versus the other is very, very different. What is a radiculitis? A radiculitis means that you've got numbness, tingling, burning down the leg, and they have radicular symptoms in a specific dermatome. Radiculopathy means that they have that numbness, tingling, burning, but they also are weak. If your patient has a disc bulge, disc protrusion, and they are weak, and a neurosurgeon said they're not a surgical candidate, and they are symptomatic, Dr. Chun and I both get a second neurosurgical opinion. Now, 2 neurosurgeons saying no surgery. Even if the patient is symptomatic, this is an indication to treat because this patient is weak, and that weakness can progress. If I am able to discern weakness in a patient, that means that they have lost 20%, 15 to 20% of their axons. If the patient knows they're weak, they've lost 40% of their axons. Meaning if a patient says that they can no longer get up from a seated position because they've got weakness in the leg. Well, this in particular would be going upstairs, right? My calf muscles aren't strong enough. I can't push to go up a stair. That's significant. You've got to treat this. Now, we talked about the traditional application of steroids. We know that steroids do a couple things. Steroids, we know, are number 1, catabolic. They break tissues down. Number 2, they increase blood sugars systemically. 300, 400, 500 for a while. All right. Do exosomes systemically elevate blood sugar? They do not. This is Wharton's jelly-derived exosomes. Are they catabolic? Actually, they're not. And this is what makes them very, very different. If you use an umbilical cord-derived exosome, and you would be using that under experimental use, number 1, it will down-regulate inflammation. But number 2, in this case, number 3, it's anabolic. This is critically important. It is because cortisone and its derivatives are catabolic that the repeated application of steroids leads to joint replacement. Exosomes are anabolic. They build tissues up. That is fabulous, right? Now, what would you use from an exosome standpoint? Well, Platinum has a couple different products. We'll get into products as we're talking about these cases, all right? In this case, if you wanted to systemically downregulate inflammation, you can do systemic application, or you can actually do focal. Systemic application. You can do IV. You can do nebulized. You can do intramuscular. IV is certainly the most efficacious. Nebulized following, and then intramuscular. The product you would use here is something called nano air or nanosomes. We will get into products and placement after just a little more discussion. Focal application. Focal application, you're looking at either, if you're a pain doctor, 3 routes, right? Transforaminal epidural steroid injection, probably at the level, at L5, plus S1 is probably gold standard. I would probably choose Nano Air. Nano Air is a lyophilized exosome. It is 50 billion exosomes. I would reconstitute that with 3 cc's of normal saline, and I would drop 1.5 cc's around the pedicle of 5, and I'd put 1.5 cc's in the foramen, the sacral foramen of S1. The other option would be interlaminar, right? You could go interlaminar, in which case I would still use Nano Air. I would reconstitute with 5 cc's. I'm sorry, 3 cc's as well. I'd probably use 3 cc's. I'm a low volume guy. Some people do interlaminars with 5 cc's. I tend to do 3. So we're going to say 3 to 5 cc's of normal saline. And you could place it interlaminar at L5S1. Is there another option for a disc at L5S1 from a focal application? There is. Caudal. Again, I'm a low volume guy, so I use 5 cc's of normal saline, and I would reconstitute Nano Air and apply it in the caudal epidural space. Now, if you're not a pain doctor and you have a patient with discogenic low back pain, let's go through that. I know this is very, very busy, all right? But if I've got this very same patient, and the patient's in my office, and say I am in a med spa, all right? Say I'm a chiropractor, integrated chiropractor. Say I'm not a pain doctor at all. I'm just an internal medicine doctor, and I love biologics, and I have a predilection for pain patients. Stop using narcotics altogether, and I want to do something different. All right? This patient's 26 years old. Our goals, number 1, and I think it's critically important that you know what your goals are before you even apply a biologic. Number 1, reduce inflammation. Number 2, we know with a disc herniation that's 4 millimeters, what is our pathology? Our pathology is to the nucleus pulposus. It's also to the annulus fibrosus. Because if there wasn't pathology of the annulus fibrosus, we wouldn't even get a disc herniation. So our pathology is type 2 collagen, as well as type 1 and type 3. So my goal is, number 1, reduce inflammation. Number 2, it's collagenic differentiation. If you have never heard me lecture or talk, you probably have never heard this term. Collagenic differentiation is the term any and all of you should be using instead of stem cell. Using the term stem cell suggests that a product is going to heal a patient or cure a disease. And that is not what any biologic does. What a biologic does, if it's something like Wharton's jelly or a Wharton's jelly derived exosome, is that it influences microRNA to down-regulate inflammation. And after down-regulating inflammation, once the inflammation is quelled, then the body can actually heal itself at a cellular level by making new collagen completely dependent on the collagen-based building blocks in the region. That is collagenic differentiation. Now, we know that the nucleus pulposus is type 2 and type 1 and type 3 cartilage. There are some doctors that like to do an intradisc with just PRP. I don't know why they would do that, right? Because they're only addressing one paradigm, just the type 1 collagen. There are some doctors that really like to use Viadisc. Viadisc is a problem that is just dehydrated type 2 collagen. Well, they're addressing the nucleus pulposus, but they just forgot completely about the annulus fibrosus. Those are half measures, all right? So if my goals are number one, reduce inflammation, I would use first nano air or nanosomes. Nano air being 50 billion lyophilized exosomes, nanosomes being 180 billion cryopreserved. Once I've calmed the inflammation, now the body can go through collagenic differentiation. So if I'm not a pain doctor, I'm not going to put in a needle through the very same IV. I can use a product like NanoFlow. NanoFlow is 40 or 80 million MSC derived growth factors. It's a sledgehammer of growth factors. Fabulous product, completely aqueous. And if I've quelled the inflammation first, can I then go and apply my NanoFlow and supplement that cartilage, complex cartilage-based defect with collagenic growth factors under an experimental use paradigm? You betcha. You betcha. What would I do after this? Well, almost all discogenic pain is inflammatory. And on a 26-year-old patient, what I would probably do is once I quelled the inflammation and once I supplemented some of the collagenic growth factors, I would probably move into a maintenance. And I would probably do nebulized nano air quarterly. If all of you are not in our Facebook group, the Facebook group, again, is called the Institute of Regenerative Education. In that Facebook group, we have lovely videos showing you how to nebulize from start to finish. This patient nebulizes quarterly. They downregulate inflammation. They probably manage a lot of their symptoms from this case. Let's do case number 2. Dr. Chun, hit us with case number 2.
Thank you for that, Dr. Martin. Case number 2 is actually a lot of patients of mine. Younger patients that have no disc pathology, also in a car wreck, issue of rear ends, where they get whiplash injury to set joints. As we all know, as pain doctors, set joint syndrome is not something that is something that is radiologically diagnosed, but it's going to be a clinical diagnosis based on CAMS or facet loading or whatever you like to use as terminology for that. And these are patients that have had either medial branch blocks or facet joint injections along with rhizotomy, but continue to have pain.
So what Dr. Chun is talking about is kind of the mainstay for almost all of us in our practices. 35-year-old female, status post motor vehicle collision. And she presents to you with axial neck pain and headaches. Now, most of us are used to dealing with macroscopic issues, things that we can see with our eyes, things that we can see on X-ray. The problem with motor vehicle collisions, in particular, a motor vehicle collision where the patient was hit from behind and they got a whiplash, is they get a traumatic acceleration, deceleration, and they end up with something called a facet syndrome. Now, when you look on X-ray, your X-rays are negative. You don't see arthritis of the facets. You don't even see inflammation of the facets. So maybe you get an MRI. And when you get the MRI, there's nothing there. Maybe there's a tiny little disc bulge, 1 millimeter, 2 millimeter disc bulge, right? But you don't see inflammation in the facets. You don't see arthritis in the facets. You don't see any of that. So what the heck do you do? Well, Dr. Chun, walk us through this patient. You said the patient came in, and many of them typically, right, would get medial branch blocks, right? Usually with cortisone, correct? Many of them would probably get muscle relaxants. They get NSAIDs. And many of them still are symptomatic. Is that correct?
Yes, that's correct. I will sometimes, depending on the patient, do intra-articular facet joint injections, but medial branch rhizotomies for health insurance that ends up paying better. So a lot of people do go that route. If I don't know how much I can treat, I will do intra-articular facet injections, but I still use it diagnostically for rhizotomies if I do that.
So we'll talk about facets, or we'll talk about medial branch blocks. The facet joint means that you're actually putting the needle in the joint itself. Medial branch block means that you're using lidocaine and you're actually anesthetizing the facet joint itself, for those of you that aren't pain doctors. Both of these procedures are typically used to try to get at an etiology of the patient's pain. When you have axial neck pain and the MRI is negative and the X-ray is negative, right? What supports the neck and allows the neck to turn right and turn left and extend without flipping back over on itself and then flex forward are the facet joints. Now, those facet joints, type 1, type 2, and type 3 cartilage, right? So this is a very traditional approach that at times works. And it may work for some of the axial neck pain, but what about the headaches? Dr. Chun, what are these headaches usually like? Are they usually vascular in nature?
No, they're usually like a lot of times they'll have like neuralgia, type of headaches, base of their skull.
So when a patient walks into your office and they talk about a headache, all right, it is critically important that you don't read the chart and assume that their headaches are migraines. Migraines are very specific. Throbbing, aching, pulsing. Feels like my head's going to explode, right? I have to be in a cool, dark place. I can't have loud noises. I can't have bright lights. That's very specific for migraine. These patients might get a migraine, but that's not the primary etiology. The primary etiology is that with whiplash syndrome, you typically irritate the facet joints at C2 and C3, which can irritate this third occipital, the cranial nerve 3, which is the occipital nerve, or one of them, right? And they will get something called occipital neuralgia. So if we're looking at the patient's head from the back, these are the ears, right? Here's kind of hairline, right? Here's how he parts his hair, right? Neck, shoulders, hairline, right? The occipital ridge sits about right here. And along the occipital ridge, you have the greater and lesser occipital nerve, and it will give you pain that radiates up over the ears like this. Starts in the back, radiates to the front. I used to do occipital nerve blocks all the time, and I would get referrals from headache specialists all the time who just didn't know how to treat this. The occipital neuralgia is really easy to treat. You just ask the patient where the pain starts. It starts kind of back here and goes this way. Then you actually check their sensation. And if their pain is all on the right side and you touch the side of their head, and then you touch the other side, usually they will have loss of sensation or increased sensation on the symptomatic side compared to the other. Now, here's where things get interesting. Typically, steroids may work for this, but patients who've had a lot of steroid shots can get tolerant to the application of steroids. So if any of you have heard me in the past talk about the application of biologics for neuropraxic deficits, here's where things get interesting. So as opposed to putting lidocaine or cortisone into these facet joints, which are inflammatory, there's no degeneration of the joint. There's just been a traumatic smacking of the joint. The degeneration hasn't started. It's just inflammatory. So instead of using cortisone, could you have used something like nano air and reconstituted it in 3 to 5 cc's of normal saline and split that across the cervical facet joints? You betcha, right? If the patient has inflammatory, irritating, burning pain, could you also, having used 5 cc's, touched up the facets? Because you can only get half a cc in each facet joint. And so if you do C3 and C4 and C5 right and left, you're looking at maybe 3 cc's of volume. But what if you used 5 cc's of volume for that 50 billion vial? Could you drop 2 cc's just subcutaneous over the greater occipital prominence to see if it actually helped the occipital neuralgia? Yes, you could. Could you do anything else? Well, as a matter of fact, when we look at a nerve, every nerve actually has 3 layers. There's an outer called the epineurium. There's the perineurium and the endoneurium. And we're all familiar with myelin. Myelin piles up on the nerve like this, right? And information travels down the nerve by jumping between the spaces in the myelin, the gaps in the myelin. And this is called saltatory conduction. It's kind of like driving from here to LA and jumping every 5 cars. You're going to get there much faster. Well, if I have damage to the outer third of the nerve, can I apply a biologic for that? Well, interestingly enough, the epineurium itself is dense irregular tissue. It is type 1 and type 3 collagen. So could you apply Wharton's jelly here if the inflammation was calmed? You betcha. You could take something like nano jelly, which is maybe one of the most popular Wharton's jellies, that platinum has to offer. Nano jelly is 70 milligrams of Wharton's jelly in 3 cc's of normal saline, and the product's dirt cheap, usually around $200, which makes it less than most PRP kits. So if the patient's inflammation had calmed, and you use, say, Nano Air first to calm the inflammation in the facet joints and then calm the occipital neuralgia, could you come back 2-4 weeks later and then take that nano jelly and drop some nano jelly in, say, 3 and 4, right? And then just put a cc or 2 right around that occipital nerve region? You sure could, right? Now, the reason we calm inflammation first is very simple. In the presence of inflammation, the body will not go through collagenic differentiation. It simply doesn't happen. Think about it like this. If your patient is screaming at you about a $10 copay, have they heard anything you told them about the prescription that you're asking them to take? They've heard nothing. Nothing. The same is true with the body. If there's a ton of inflammation going on and that patient has a ripping, burning occipital neuralgia, you're never going to get collagenic differentiation. You have to calm the inflammation first. These are 2 cases, but let's get into scope, right? And the reason I like scope is because if any of you were to know Dr. Chun, he and I see just about anything and everything that walks in the door, because pain doctors are essentially port of last call. If a doctor can't figure out what's causing it, they send it to us. And then it's our job to figure it out. The number 1 referral to your clinic is going to be back pain. Whether you're a pain doctor or not, back pain is the number 1 referral to any doctor's office. Number 2 referral is joint pain. This is typically large joints. This is knees, shoulders, hips. Number 3 referral, now, it's actually body pain. And this is very nondescript. This is, I don't feel good. I hurt everywhere. What is driving back pain? What's driving back pain is typically, number 1, inflammation. And number 2, cartilage-based degeneration. What about joint pain? What's driving joint pain? Number 1, inflammation. Number 2, cartilage-based degeneration. It can't be the same for body pain, can it? Okay. Let's take a patient with rheumatoid arthritis, polymyalgia rheumatica, lupus, Sjogren's. Let's take long COVID. Let's take chronic Epstein-Barr. Let's take any chronic systemic condition. What's the number 1 etiology for the pain? It's inflammatory. What's number 2? Number 2 is still collagen-based degeneration, but not always in the way that you think about it. If I have ripping polymyalgia rheumatica, do I have multifocal joint pain? You betcha. Is there going to be some collagen-based degeneration? You betcha. Just from the autoimmune disease itself. But there's also going to be degeneration due to secondary and acquired issues. Are these people as active as they were? Absolutely not. They're not active at all. How are their body mechanics? They're all compensating. They are all setting up all sorts of paradigms where they have aberrant muscle tightness, where they have compensation in their gait, in their standing, in their sitting, in their sleeping, which all end up leading to collagen-based defects in and around the spine, in and around small and large joints that end up being focal points for pain. Now, all of you looking at this may be thinking to yourself, well, man, I mean, there's a lot of ways that we could address this. Tons of ways we could address this. So how do I do it, Dr. Martin? What's my process? How do I even start? Well, in a lecture many moons ago, probably a year ago in the Facebook group, I drew this. I drew a simple triangle, all right? And on that triangle, right, I put inflammation here. Cartilage-based degeneration here. I put function up here. If I have lots and lots of inflammation, and I have lots of cartilage-based degeneration, what happens to my function? My function suffers dramatically. So my goal is to keep in this paradigm, to preserve function at the top. I need inflammation down. I need inflammation at the bottom of this paradigm. And while I'm lowering inflammation, I need to do everything that I can to increase collagen differentiation. And if I can do that, if I can bring inflammation down and I can increase collagen differentiation, I keep somebody's function at the top. As soon as I lower this and increase this, my function declines. So what do? I approach every paradigm 1, 2, 3. Number 1, is the inflammation systemic or focal? Number 2, is the cartilage-based degeneration systemic or focal? And then looking at my function, what is impacting my function? Because I cannot do this alone. We're still practicing medicine, right? So I still need to address function. And you may say, well, why is this so important? Well, because this function is diet. This function is peptides. This function is immune support. This function is also an aggressive look at supplements. In particular, leucine. You can't get muscle health. You can't get Leucine. You cannot get muscle health without essential amino acids. You just can't. So let's take a simple case. We talked about this, Dr. Chun and I, on the phone. Let's just take my patient with osteoarthritis, 70-year-old female. OA, grade 4/4 of the knee, according to her doctor. She has systemic inflammation? No, she's super healthy. So am I worried about doing IV or nebulizers? Not really. Does she have any focal inflammation in her knee? No, she doesn't have any focal inflammation in her knee. So I'm not putting, any exosomes here either. This is all exosomes, by the way. Cartilage-based degeneration. Does she have systemic cartilage-based degeneration? No, her only complaint is her knee. It's actually her left knee. So her problem's all focal. She's had multiple cortisone injections in the past, which means that cortisone broke her joint down. And we need to rebuild her joint back. So how do we do that? She only has degeneration in the joint. I did not say that she has a tear of the meniscus, right? And we know from our prior drawing of the knee that knee joint, right? That articular cartilage is type 2. Well, in order to get collagenous differentiation in that knee, I need a couple things. Number one, I need type 1 collagen. I need 2, and I need 3. I also need extracellular matrix, meaning I need the building blocks for microarchitectural scaffolds so that the body can start to rebuild the structure of collagen in that knee. The product we use is called NanoFlex. NanoFlex is 300 milligrams of Wharton's jelly. It is the most potent Wharton's jelly in the regenerative medicine marketplace. It's typically in 2 cc's and it's cryopreserved. So I usually add 1 cc of normal saline. Now you may ask, Dr. Martin, why are you only using 1 cc of normal saline? Why would you only put 3 cc's into that terrible joint? I already told you that she has grade 4 on 4 joint disease, which means she's got dramatic radiographic collapse of the joint space and radiographic collapse of the synovial joint capsule. So if I try to stuff 6, 7 cc's of fluid in that knee, number one, it's going to be very painful. But number two, I'm probably going to distend the capsule of that joint, disrupt osmotic potential within that joint, and cause her to get a reactive effusion. That's a problem. So I only use 3 cc's, and you may not be able to get all 3 cc's in. You may only be able to get 2 cc's. Now, we're not going to go through specific procedural applications, but what I do want to address is the specific products that Platinum has and kind of how I use them for pain procedures. And then before we wrap, I want to talk about how you use them in the practice of medicine in your office. Because at the end of the day, all this theory is great, but if you can't use it in your office, you can't make money. So we're going to do all of this at once. Typically, if you're injecting a knee joint, you're billing a 20610 or 20611. Medicare reimburses $59.95 for that all over the United States. Most of the MACs in the country do not reimburse for ultrasound. Most of them do not reimburse for fluoro. Nobody pays for J codes, so you're not getting paid for your steroid, all right? Most of you have between 60% overhead, and if you add the $5 or $10 for Depomedrol, you're looking at 70% overhead. So on this $60, at most, I'm making conservatively $20. That is not a lot. Now, what is the market rate for PRP? It is $500 to $1,500. Now, you may ask yourself, who on earth is charging $1,500 for PRP? Guys I know, usually in South Florida and in Southern California. Well, you're over here getting paid $20 to do some cortisone, which is breaking the joint down and leading to joint replacement. they're getting paid $500 to $1,500. Now, the problem is most PRP kits are about $250. So their net may only be about $250 on the low side. So how do you, if you're seeing insurance-based patients and you want to use something like nano jelly, which again is 70 milligrams of Wharton's jelly. It's cryopreserved. It's in 3 cc's. How do I get paid some cash? Do I ask for $500 or $1,500? One of the easiest models that you're already using in your office, and you just don't realize it, is the hyaluronic acid model. The hyaluronic acid, your patients are already paying cash. They're just not paying you. Because insurance doesn't pay for hyaluronic acid. No, you write the script and they go to the pharmacy. And when they go to the pharmacy, they got to pay somewhere between $350 and $400 per syringe for that hyaluronic acid. So what if you just charge the patient $400 in your office for that nano jelly application? What does that look like? Well, let's do some math. We're going to say our nano jelly costs $200. All right. Now we made $400. So our net is roughly $200. Now, how much overhead is there on cash? Do you have to pay 7 to 10% to a biller? No. Do you have to wait 6 weeks to get paid? No. You may have to pay a 3% processing fee, right? But by and large, there's not a whole lot of overhead on that Wharton's jelly. Well, if I made $200 net per procedure, and I did that 10 times a week, and I did that 4 weeks out of the month, right? Well, I'm looking at about $8,000 in cash a month. What if I buy this in volume and that price gets better? What if I charge more than $400? Any of you who are doing procedures are doing more than 10 procedures a week in your office. Most of you are doing 15 to 20 a week. $400 is a very low cash fee. And you're not billing for the procedure. You're still billing this. But Medicare doesn't pay for biologics. They're not on the fee schedule. So can you charge just for the nano jelly? And can you charge $400 for the nano jelly? Yes, you can. And you're going to make your net of $200. And depending on how many you do and how many weeks a month you work, $8,000 is pretty sexy. Because $8,000 pays a lot of overhead. It actually pays a pretty good nurse practitioner's salary a month. Pays a lot of MAs. Pays some rent. Pays some supplies. Might even pay a mortgage. A really nice mortgage. Unless you have like an 11% interest rate or something. Can you charge more? Well, sure. We have all sorts of people out there charging $1,500. What's my rule of thumb? My rule of thumb is very simple. If I'm doing any injection or IV or any therapeutic intervention and assume my cost is $200, I need to charge $200 for my cost, $200 for my overhead, $200 for my profit. You should be charging $600. That's reasonable and customary. I usually charge between $400 and $600, 2 to 3x, right? But you can just charge $400 if you want, because you're just getting going. Now, I know the sun's coming in behind me. I don't know, Beeben, can you still see this, or do we have a lot of light on the field?
No, it's we can still see pretty good actually.
Okay. So I get asked this all the time. This sounds great, Dr. Martin. You know, I want to get a bunch of cash. I want to do this. But how do I tell my patients that I'm going to charge them $600? How on earth do I tell a patient, you need to pay me $600? Let's walk through that. So we still have our knee patient. Knee patient walks in, right? Still got a lot of pain. Had some cortisone shots, had some PRP, right? PRP didn't work, right? So we still have our 70-year-old patient, female, right? Grade 4 or 4 OA, right? Failed cortisone. Failed PRP. Doesn't want surgery. Number one, what do I tell this patient? Do I tell this patient that I'm going to give her stem cells? No. I would never tell her that I'm giving her stem cells. I would say your joint, your knee joint, I've drawn this a million times, is type 1, type 2, and type 3 cartilage. And because your knee joint is type 1, type 2, and type 3 cartilage, unless I use a growth factor complex, that also has type 1, type 2, and type 3 cartilage, your body will not heal itself at a cellular level, meaning you will continue to have pain and degeneration. Notice what I did not say. I did not say that we are going to give them stem cells and the stem cells were going to cure the patient, because that isn't what happens. When you put in the appropriate growth factor complex, once you've quelled inflammation, the body will go through collagenous differentiation. And at a cellular level, the body will start the process of rebuilding collagen building blocks. In essence, healing itself at a cellular level. You are not doing it. Your body is doing it. You are just putting in the supplements to make that process happen. Now, after you've told the patient this, you may be like, man, that's cute. That's great. What does that cost? And so now you're like, oh man, oh, I don't want to sell. I don't want to sound like I'm selling here, right? I don't want to be like Johnny Watches here and like, oh, you want this watch, or oh, I got, these over here. You don't want to feel like Johnny Watches. So what do you do in this scenario? What do I do in my office? Human cell and tissue products are marketed in the United States in a couple different ways. State of Utah, state of Florida, you can use stem cells and even use the term stem cell as long as you do something called homologous use. Meaning that essentially you use a growth factor complex in a region where there's cartilage-based degeneration. Can you use exosomes? Can you use true blue stem cells to heal people? State of Utah, state of Florida? Actually, not really. Not really. But here comes the rub. You're going to love this. You're going to love this. What do the feds think? Do the feds think that you can use biologics for homologous use? They don't like it that much. As a matter of fact, they don't like it at all. So say you're in the state of Florida, or say you're in the state of Utah, and you think that the panacea of the world just opened up because now you get to market stem cells, you get to stand on every corner and put on the chicken suit, and you get to dance around and advertise stem cells. Come here and get stem cells. Get stem cells. We're going to cure everything. And you comply with the state of Utah and the state of Florida to the letter of the law. Can you still have the long arm of the Fed reach out and tap you on the shoulder with a warning letter? You betcha. Just because you're in compliance with the state doesn't mean that you're in compliance with federal regulations. And so I like the comfy, juicy center, right? Not way out here on the extreme. I like the warm, comfortable blanket that is experimental use / cosmetic use. Now you're like, well, Dr. Martin, what the hell does that have to do with talking about stem cells in my practice and doing a knee injection on a 70-year-old and getting her to spend $600 or $700 or $1,500 for a procedure? Well, I'm going to tell you. Say in your office, you did an observational study. And you in particular did an observational study looking at the application of biologics in osteoarthritis. Now, if you're doing an observational study, is that experimental use? Yes, it is. And in that experimental use scenario, do you have to just use Wharton's jelly? No, you don't. You may love PRP, and everything that I said terrible about PRP, you may be like, Dr. Martin, you're a jerk. I love PRP. You know what? If you're doing an observational study, please use PRP, right? How do I use PRP if I'm going to use it? Or A2M? I use my A2M. I use my PRP plus Wharton's jelly. And Platinum has a sexy little product called Nano DPM, dehydrated particulate matrix, 100 milligrams of Wharton's jelly, and it's lyophilized, meaning it's powdered. So can you add Nano DPM to PRP if you just love PRP? You betcha. And will you increase the growth factor complex in that product? Absolutely. It's something that I call a balanced pro-inflammatory response. You blunt the predictable inflammation from the PRP by using an immune privileged tissue. That little bit of inflammation that you cause is going to stimulate type 1 collagen, collagen differentiation, but you've already got the big boys coming, right? You got in a bar fight and you called up all your Samoan buddies and they're all coming and they're going to beat the heck out of everybody, right? Because the Samoans are bringing the type 1, 2, and 3 collagen.
Dr. Martin, we just hit the 9 o'clock mark, so I figure you want to probably get to some Q&A if possible here before we
Let's do it.
Let's do it. So I've got and I just want to say one more thing too. I love the way that you break that down, that PRP and bone marrow don't have any approvals for indication. They're actually being used as experimental use each and every day. All biologics are. And to think, you know, that one is different than the other. They're actually not in that respect. So anyways, we've got Dr. Wham. For those of us not physicians who can't inject directly into the foramen/disc, is IM into the paraspinous effective for herniated disc pain?
So I did a whole video on this in the Facebook group, and let's go through this. I'm going to make this very, very fast. All right. Super fast. First and foremost, if you cannot inject into the disc, that's okay. You don't have to inject into the disc. Most discogenic pain is inflammatory. If you're not an interventionalist, can you use a nebulizer and can you give nano air nebulized? You betcha, you can do that. All right. So nucleus pulposus, annulus fibrosus, spinal cord here, nerve roots exiting here. Well, here and there, right? Now, if I inject here in the paraspinal muscles, your biologic is going to have to go through all three paraspinal muscles. It's going to have to cross the ligamentum flavum, the posterior longitudinal ligament, the epidural space, the spinal cord, the CSF, the anterior longitudinal ligament, and then all the way into the disc. That just simply does not happen. All right. What does happen is if you inject IM here, all right, the biologic is absorbed into the bloodstream, goes through portal circulation, goes to the lungs, goes to the heart, descends by way of the descending aorta into the anterior and posterior spinal artery, and then by diffusion makes its way to the disc. Is there a role for paraspinal injections? Without question, but under a different pretext. If somebody has discogenic low back pain, are they going to have paraspinal splinting of the paraspinal muscles? Without question. Absolutely. They're going to have multifocal tears in these muscles, cartilage-based tears in the fascial components that surround every muscle fascicle, right? So can you apply Wharton's jelly for the paraspinal splinting and at the same time give somebody a nebulizer or an IV of exosomes to systemically downregulate inflammation? You betcha. And so the thing to do here would be to use nano air or nanosomes. This I would nebulize. This I would give by IV. And if you wanted to do it at the same time, I would use nano jelly and I would apply it to the cartilage-based defect here in the paraspinal muscles, above and below the lesion. If your lesion is at L4-5, get your landmarks, apply at L4, right and left, apply at L5, right and left. That's what I would do. Eben, do we have any other questions?
Yep. We had one. Let me see here. Let me just pull it up. So I answered the cryopreserved, storage, obviously. And then we've got here. No, I think we've pretty much taken care of it. The last one was the anonymous attendee asking about the implication of malpractice care of these products, but we have a broker that does all of that in the group and that we send people. Obviously, we can't even talk about insurance, and asking a doctor to talk about insurance related stuff would be kind of goofy.
Let me just, I'll address both of those in short order. Malpractice. All of you probably have a primary malpractice carrier. My suggestion, you may not be able to convince your primary malpractice carrier to allow you to use biologics. So don't even bother with it. and just get a secondary part-time policy. You don't have to get a full-time secondary policy. You can get a second part-time policy for biologics. And if you go into the Facebook, Mr. Trombley is a fabulous broker, and his information's in the Facebook group. All right. I'm going to touch on this really quickly because this is critically important. Under human cell and tissue products, you hear all the time that PRP, BMAC, SVF are the only FDA approved biologics. That is not true. It's not true at all. What PRP, BMAC, and SVF are is that they are FDA approved 510K cleared kits. PRP, BMAC, and SVF are plastic kits from China. They are approved as a medical device. No different than this would be if I got a 510K for a washable skin marker that I could use in surgery. It's just a medical device. But if I add blood, bone, and fat to these 510K cleared kits, now I have a human cell and tissue product regulated the exact same way Wharton's jelly is, as a Section 361 product that cannot be used to diagnose, treat, cure, or prevent any disease. So if your rep is telling you that PRP is FDA approved to treat osteoarthritis, they are lying to you. If your BMAC rep is saying that you have an FDA approved kit to treat intradiscal or osteoarthritis, they are lying to you because it's just not true. These are 510K cleared plastic kits. They are not human cell and tissue products. When you combine them with blood, bone, and fat, they become a human cell and tissue product regulated under the same statutes as Wharton's jelly, meaning none of them can be used to diagnose, treat, cure, or prevent disease. This is why we encourage experimental and cosmetic use. Any last questions?
We've got, do you suggest any blood work before, after, or while using biologics?
I love it. I love it. I love it. I love it. Okay. Hard and fast no-nos. All right. Now, this isn't for everybody. Some of you have very specific practices. I'm just going to call it the no-nos. Number one, pregnancy. Please don't ever ask me if it's okay to give a biologic in pregnancy. I'm going to say no. Number two, breastfeeding. Please don't ask me if it's okay to use a human cell and tissue product if the patient's breastfeeding. You just have to ask yourself, do I really want to own that patient for 18 years of their life? Do I really want to deal with anything and everything that could go wrong in delivery and have it be my fault because I gave a human cell and tissue product while the patient was pregnant or breastfeeding? I don't want that liability. I would suggest that you don't want it either. Number three, cancer. If your patient presents and states that mom had breast cancer, sister had breast cancer, daughter had breast cancer, but I don't have cancer, would I do some screening? You betcha. All right. I would not give that patient a biologic because with that crazy strong family history, more than likely they either have breast cancer and just haven't found it yet, or they're getting breast cancer. If the patient has active cancer, do I use biologics? In my practice, I do not. But I don't treat patients with active cancer. Some of you see patients in your medical practice and you see them and you alternatively treat cancer with things like peptides and diets and even biologics. If that is your specific niche practice, go for it. What are the other general recommendations? Number one, no NSAIDs, 3 days before and 7 days after any biologic application. NSAIDs denature the biologic. Number 2, no lidocaine. Mixed with the biologic. So can you do a skin wheel if you're doing a knee injection? Sure, go for it. Do a skin wheel. But do not mix it in the joint with the biologic. Lidocaine will denature your biologic. All right. Finally, what about activity? What can they do after they've had their application? Nothing that's going to cause them to sweat for 72 hours. No hot yoga. No standing out in the sun in Las Vegas at 3 p.m. for 4 or 5 hours. No hot tub, no sauna, no hot yoga, right? No dancing if you're going to sweat when you dance, all right? Even if you think you're going to play golf, if you're going to golf in Florida in the middle of the day in the summer, you're going to sweat. Please wait 72 hours and then gradual return to activity. These are my no-nos, all right? These are the things that I have a hands-off approach on. Any other questions?
Yep, we've got. Okay, we answered that one. Answer that one. We've got someone that's bringing up Dr. Pratt. So still not have talked about the intradiscal, what product. I guess Dr. Martin, I did message that they could use Biodisc. Biodisc is our sister company. It's a lyophilized amniotic membrane that is registered actually with the FDA and registered as a 361 for intradiscal application. You can bill a 0627T, $12,000 reimbursement. So I already tagged that in there. But Dr. Martin, I guess if you don't need something papered up, right, that's not overpriced because there's insurance involved with it. Do you want to talk about what you would do in the intradisc cash-wise?
I'm going to hit it all really fast.
And then also, here's another one. Is PRP safe in the epidural space? If a car accident patient doesn't want cortisone, is there another option? I just do those 2 discs ones.
Yep, and then we'll do intradisc down here with PRP as well. I can answer PRP really fast. I would never put PRP in the epidural space, ever, never. Why? Because it's pro-inflammatory. It's going to cause inflammation. And you've got an inflammation already going on. Number 2, the risk of infection is insane. Number 3, what is in PRP? Lots of fibrin. What does fibrin tend to want to do? It tends to want to clot. Is there any possible reason I would want something that's going to cause a thrombus in the epidural space with the possibility that's going to get into the, circumflex artery or one of the perforating spinal arteries and give somebody a transverse myelitis? Oh, for the love of God, no. You might as well just take your medical license and vomit on it, then defecate on it, then light it on fire, right? And then drop 50 M80s on it and decide that that's what you want to do, because you're definitely going to lose your license. Definitely. Now, I enjoy the intradisc discussion because it is misinformation at its finest. And I'm going to do this fast because I know you guys want to get to your dinner. Viadisc came out in 2020. Viadisc was a dehydrated nucleus pulposus. It is a lyophilized type 2 collagen. This seemed very sexy because the nucleus pulposus is type 2 collagen, at least 90%, right? The problem is that the VAST trial, published in 2021, was type 2 collagen, this lyophilized, plus a cryopreserved cellular product that the makers of Viadis refused to disclose to the FDA. And because they refused to disclose what that cellular product was that was cryopreserved, which we all know was Orton's jelly, right? They changed it. So is 2025 Viadisc the same as 2021? No. In 2021, it was this. In 2025, it's just this. So all of the results from the VAST trial published in 2021 that showed really, really significant improvements in pain, well, that happened because they used lyophilized type 2 collagen plus probably Wharton's jelly. But that's not what they're selling right now. So don't fall for that nonsense. So if you just wanted to do intradisc, understanding that the nucleus propulsus is type 2 collagen and the annulus fibrosus is type 1 and type 3, I would use Wharton's jelly. Platinum makes a specific product for that. It is NanoFlex 150. It is a 1 cc product. It was specifically formulated for intradisc for cash, meaning that 1 cc is what is recommended by all neurosurgical societies for therapeutic intradisc application. NanoFlex is 1 cc. It's perfect. This is a perfect intradiscal product. It's type 1, type 2, and type 3 collagen. What is Biodisc? Biodisc, it's new. It's pretty hot. And if you are in 2 different MACs, if you are in Novitas or you are in First Coast, insurance pays for it, meaning Medicare pays for it. Biodisc is amniotic membrane, specifically type 1 collagen, type 2, and type 3. Biodisc is a little bit
GDO5 or whatever that
growth
original
differentiating,
formulations have. Yeah.
growth differentiating factor 11, right? Growth differentiating factor 11 is fascinating. Growth differentiating factor 11 only exists in the umbilical cord, and growth differentiating factor 11 in a wonderful study published, I believe in 2021, same year, demonstrated that if you just increase growth differentiating factor 11, the nucleus pulposus rehydrated. Fascinating, fabulous paper, right? Well, Biodisc is a little bit different. When you do intradiscal applications, whether it's with Wharton's jelly or with Biodisc, the typical application is to the nucleus pulposus. Biodisc, the application, is actually to the annulus fibrosus, because it takes a fissure in the annulus fibrosus for the nucleus to herniate. Now, some doctors will take this lyophilized amniotic membrane and they'll reconstitute it with 2 cc's of normal saline. And they'll put 1 cc in the annulus and 1 cc in the nucleus, which is super sexy. I like that a lot, right? Or you can just put all 2 in the annulus fibrosus. Entirely up to you. But this is reimbursed by insurance very high. You need to be in Novitas or First Coast. It's a novel application, and that it's applied where the problem is, in the annulus fibrosis, but you can alternatively apply it in the nucleus and the annulus. If you were just going to use Wharton's jelly and you were going to bill this for cash and you were to use NanoFlex 1 cc, would I personally add another ½ cc of saline and put half in the nucleus and half in the annulus? I would, because I think it'll work better clinically.
There's
Because
another one,
again,
Dr. Martin. It says there's another one that says, in the case of use with exosomes via transfemoral approach, could nano PRP be used in epidural space?
oh, for the love of God, no. Okay, remember, anything with Wharton's jelly, whether it's nano jelly, NanoFlex, well, really nano jelly, NanoFlex, 150 or 300. These products have extracellular matrix. We do not want extracellular matrix in the epidural space. All right. Could you technically, theoretically put NanoFlow in the epidural space? You could. Would you do it for radiculitis or radiculopathy if there was inflammation present? No. Because NanoFlow is not an exosome. It's not going to down-regulate inflammation. So where do you use NanoFlow? And this is fascinating. I talked to a pain doctor this weekend who's doing this. Fascinating, fascinating. I didn't even talk to Beeman about this. In patients with severe neuropathic pain, we do things called dorsal root ganglion blocks. Now, typically with a DRG block, which is the sensory ganglion off the nerve root, we're typically doing anesthetic to see if that's the source of their pain, right? Well, what he decided was, if you have a neuropraxic deficit in the peripheral nerve, and you can use Wharton's jelly for that, and I've got a patient with really bad neuropathic pain, and I think it's coming from the spine because they had a massive disc herniation or they had arachnoiditis or something like that, and that's all calmed down, couldn't I apply an aqueous Wharton's jelly for a neuropraxic deficit at the DRG? And he started using NanoFlow transforaminal and specifically around the dorsal root ganglion for people with refractory neuropathic pain prior to spinal cord stimulation. And sure enough, he's getting really, really great results. Now, this is probably one of the more exciting applications of biologics in spine and in pain that I've come across anywhere. And so did I beg him for like 20 minutes to publish his results? Of course. I don't know if he's going to or not, but it would be a fascinating paper. But the trends that he's seeing are really, really exciting. This is what I'm talking about, practice of medicine. When you understand how a biologic works, these are not patients with inflammatory pain. These are patients with strictly neuropathic pain. There is no inflammation. There's no role for an exosome in the spine. But there's bad neuropathic pain, and he understands that that could be a neuropraxic deficit at the region of the dorsal root ganglion. And so what is he going to use? He's going to use a tissueless Wharton's jelly, no extracellular matrix that would cause a clot. And he's going to put collagenous growth factors right around that nerve to see if he can get the body to go through collagenous differentiation at a cellular level in the dorsal root ganglion to relieve neuropraxic deficits and hopefully ameliorate neurologic or neuropathic pain. Completely fascinating. Completely fascinating.
Well, and anyone that's chasing that too, guys, remember, obviously, experimental use and cosmetic topical use, but anyone that needs or wants to chase something down specific, like some of this, more out there stuff, and that's going to produce some fabulous data, we are set up with an institutional review board and IRB. So if you did want to collate that data and have Dr. Martin work on getting you published, Dr. Martin has published many and worked on many different papers. And as you guys know, our chief scientific advisor is the #1 published PhD in the world, Dr. Ashin Gupta. Him and Dr. Martin could polish a paper for you with your name on it, with your data, and he's the chief editor of 3 major medical journals, including, I think, MDPI. So anyways, that's all available and ready to go too. So you can just plug right into it. Protocol for neuropathy in the feet. I guess that neuropraxic deficit, you can just latch right onto that.
It's exactly that. So we're going to draw, we did this in the podiatry lecture, and this really lit some people up, and they just loved it. All right. Now, first and foremost, remember, my paradigm is, all right, is there inflammation? I need to address that first. Once I've addressed the inflammation.
Can you also address, because it's inflammation, there's issues, NSAID steroids absence prior or after to the procedure as well?
Okay. So of course we don't want to use NSAIDs before, right? All right. Yeah, foot, dorsum of the foot. We're going to say big toe. All right. This is big toe, so this is medial malleolus. All right. Up here in the leg, here's the leg. Here's the knee. This is the lateral aspect of the leg, and this is the fibular head. Okay. So here's your knee, here's your quad, here's your calf coming down. All right. Neuropraxic deficits, again, are an injury to the outer third of the nerve. Number one, we want to get rid of the inflammation. So whether that is nano air or whether that is nanosomes, that is entirely up to you. But I would do that first. And then 2 weeks later, I would do a series of 3 applications at 0, 4, and 10 weeks. Okay? If you look at the lateral aspect, the sciatic nerve comes down the back of the leg. The peroneal nerve wraps just caudal to the fibular head and splits into the superficial peroneal nerve that supplies the top of the foot and the deep peroneal nerve that supplies the first web space. The tibial nerve wraps around the back of the leg and goes through the tarsal tunnel and splits in the calcaneal branch, the medial plantar branch, and the lateral plantar branch on the plantar aspect of the foot. So if I was to apply a biologic for a neuropraxic deficit, I would apply my nano jelly which again is 70 milligrams of Wharton's jelly. I would do 1.5 cc's at 2 different locuses. 1.5 cc's just sub-Q, just caudal to the fibular head, and just proximal to the tarsal tunnel. This is just sub-Q. You can push nano jelly through a 31 gauge needle. You do not need BLT. You don't need a skin wheel. You can just simply use cold spray or just simply do the injection, right? But just superficial 1.5 cc sub-Q, extraneural outside the nerve, just distal to the fibular head and just proximal to the tarsal tunnel, and you will cover top of the foot and bottom of the foot, all right? But most neuropraxic deficits are inflammatory, so I start with either nano air or nanosomes, and then 2 weeks later, I do my first nano jelly, and then repeat it at 4 weeks and repeat it at 10 weeks. Again, 1.5 cc's each site. This is very, very successful. Can you use nano jelly, carpal tunnel, ulnar neuropathy, proximal medial neuropathy, radial neuropathy, if they are neuropraxic deficits? You bet. Suprascapular, right? Suprascapular fossa for refractory shoulder pain, of course, right? You can use a lot of these peripheral applications for some peripheral neuropraxic deficits, and they work very, very well. Ilioinguinal neuralgia, post-hernia raphy, right? ASIS, 2 finger breaths, drop it just below the ASIS in the distribution of the ilioinguinal and genitofemoral nerve. Fabulous for somebody with recurrent neuropraxic deficits post-hernia raphy. It's usually not.
What about the pudendal nerve?
Pudendal neuralgia? Pudendal neuralgia is a little bit different, all right? Pudendal neuralgia, the way to do that block, it's actually one of my favorite injections. It's called a cluneal nerve block, all right? That cluneal nerve block, you have to do under X-ray. You should do it under X-ray. For any pain doctor, they know how to do this because it's just a great block. So the patient is lying on their stomach. You are looking at their sacrum, right? Right at the sacrococcygeal joint, you're dropping a needle. And just anterior to the sacrum, you're putting a little bit of contrast to make sure that you are in this region and not in any vessels or bowel, right? And because this is at times inflammatory, could you drop exosomes there? Yes, you can. This is from a lateral approach on fluoro, lateral X-ray approach. All right. But you could also drop NanoFlow there. It's cluneal nerve block, fabulous block. Typically for pudendal neuralgia. Now, would I do a diagnostic block with lidocaine or marcaine first to see if that was actually the culprit? You betcha. And if it worked, and I thought it was inflammatory, would I use exosomes? Yes. And then a second application after the exosomes, I would probably use NanoFlow. And you could get away with like 1 cc of NanoFlow and a cc of saline. And that would be perfect there. You could just use nano air and maybe 2 cc's of saline, and you could drop that. And then 4 weeks later, drop your NanoFlow. If your diagnostic cluneal nerve block worked first.
Perfect.
This, unless you know what you're doing here, you should not do this. This is not to be done blind. This is not to be done under ultrasound.
Perfect. Okay, last question, and then guys, we're gonna head out. So, what is the adverse effect of sweating on the biologics? I guess just don't
So,
do it, right? But
yeah. So I have somebody with a knee joint, right? And I've decided that I wanted to put my biologic in the knee because I want collagenic differentiation to happen in that knee joint. Well, ideally, I want my biologic to stay here. So if I decide to exercise a bunch and I increase metabolism significantly here, whatever biologic is focal and local here, right? If I get a lot of blood pumping in here and a lot of volume pumping in here, it's going to sweep the biologic out away from that joint, right? And where's it going to go? It's going to go into the muscles, the big quadriceps muscles, right? And so all your biologic is going to leave that joint and then go up into your muscles, or you're going to sweat it out, right? So what I prefer is if I'm going to put a biologic in a place, I want it to work there. That's the point of putting in the biologic in, right? That's why I have them. The other thing is very simple, right? If I'm starting the process of collagenic differentiation, or I'm just remodeling inflammation, I just want to give it some time to work, you know? I mean, unfortunately, you know, all of us have to see like marathoners and pickleball players, and they're both a similar mindset. You can tell a runner not to run for 3 days, and they'll be like, no problem, doc, I'm not going to run. And I swear to you, 12 hours later, they will call you on your cell. Like, doc, it's 4 a.m. I feel great. Where are you? It's 4 a.m. Why are you calling me on my cell phone? Oh, I'm 6 miles into a 25-mile run. I feel amazing, doc. Thanks. You know they're not going to listen. So I say 3 days because maybe I get a day out of it because most patients don't listen. And at least it's a day more for the biologic to start the process. Ultimately, I'd like 3, but I'm just a realistic guy. Depending on the individual, I'm lucky if I get a couple hours. I've had patients call me same day. Doc, I feel amazing. I'm already at the gym. What did I tell you? I don't know, I know, but I'm not going to hit it that hard. I just want to get the blood moving.
so
You do what you can.
we got 2 questions based off of your last piece there that are semi-similar. What you're calling a Keneal block is what I would call a ganglion impar block.
I'm sorry, ganglion umpire block. That's right. Sorry, ganglion umpire block.
And then
My
the other
apologies.
question was, what about stellate ganglion block?
Stellate ganglion block?
Dysautonomia.
Dysautonomia?
Yeah.
So, and yes, I'm sorry, ganglion umpire block. My apologies. I said cluneal nerve block. I was wrong. It is exactly that. So whoever brought that point, thank you very much. Stellate ganglion, complex regional pain syndrome, right? We know it to be, you know, a dysautonomia. We know it to questionably be inflammation. We know it's neuropathic. We know it's neuropathic. If I did a stellate ganglion with marcaine and it was significant and it worked, I would still start exosomes first and then follow with NanoFlow. I probably wouldn't do NanoFlow first. I would want to see if there's any inflammatory issue to that process first. And then I would apply NanoFlow. I only know about 2 doctors in the country that are doing stellate ganglion blocks with biologics. And both only use exosomes. And I've approached using a NanoFlow with them, and they feel like the exosomes are working better for them and they're actually getting good results. And so they're going to stick with what they're going to stick with. I have one and he's contemplating the 1-2 step. But right now he's just, he's got exosomes in his head and he's getting results. And so he's happy.
What do you think about an SGB block for PTSD?
So the sphenopalatine ganglion is interesting. You've got a nose, you've got your superior turbinate, you've got your middle turbinates, right? And then you've got your inferior turbinates. And ideally, your cribriform plate is up here and you've got sphenopalatine ganglion here, and you're supposed to put a sphenocath through perfectly between the superior and middle turbinates, and then juxtaposed to the sphenopalatine ganglion without hitting the sphenopalatine ganglion. Now, ideally, you're supposed to do that in reverse Trendelenburg with their head down here and their feet here, right? And then you got to put them through Chinese water torture where you have to put 1 drop every 3 minutes through that sphenocath. I'm not a big fan of that. I just put a nebulizer mask on and I have them inhale through the nose. Because you actually have 4 routes of cross here. The cribriform plate is 1, the olfactory ganglion is 1, the olfactory mucosa is 1, and so is the sphenopalatine ganglion. And so for me, I like this much better than just this. And this is tortuous. The other thing is, if you put that sphenocath in and you push a bunch of volume really quick, what happens? Well, usually the fluid, because the patient's sitting up, goes through the nasopharynx and then drops down into the oropharynx and into the stomach. The bioavailability in the stomach for supratentorial issues is not that great. I'm being facetious. It's terrible. It doesn't work at all. So I would just put, you can take a pediatric mask and just cover the nose and just have them inhale through their nose, exhale through their mouth. I have had people that have made custom nasal cannulas and they nebulize through a nasal cannula so it all goes in the nose. That's really, really interesting. I don't know where they're getting their custom nasal cannulas from, but would be a great, great patent to specifically have a cannula sitting in the nose and drop all of the biologic up into the nose, as opposed to sitting out here in a mask. But I like it for neurodegenerative. I like it for post-stroke. I like it. This is experimental use only. I like it for early Alzheimer's. I like it for any neurocognitive issue with immune or long COVID. I've seen it with schizophrenia. I've got a doctor who's actually a psychiatrist who's starting to use nebulized exosomes for mood disorders that are refractory to just typical antidepressants and antipsychotics. And he believes that there's an element of neuroinflammation in psychiatric disease. And so he's trying nebulized exosomes and getting fabulous results. He's already like a believer.
So Dr. Martin, let me just break in on that. I know a bunch you just shot up more questions, but I want to just recap on the fact that, guys, this is why we do what we do with Platinum. We've created a separate outside medical board, right? None of this has anything to do with Platinum Biologics. This is the outside IRB setup, everything else where you guys can talk and work freely together. And all we do is just offer products, right? From a Platinum side, Scalable and the outside medical board. So obviously we can't make any claims. We don't make any claims. We don't treat or cure any diseases, but Dr. Martin speaks to an average of over 50 to 100 doctors per week. And just so you know, we move over 10,000 units of one SKU per week. Per week. Dr. Martin, you can book a peer-to-peer call with him directly through our website. If you go to platinumbiologics.com, you can go to the About Us tab, and there is a peer-to-peer call where you can talk directly about your clinical needs your economic needs, your even sales, right? Because this is cash. Whether you like it or not, this is selling. Now, you can disguise that as education all you want, but there is an element to that. And the quicker that I see doctors embrace that, we have some doctors, we have one that's doing over $500,000 a month in cash. It's an integrative practice. So there are some people throwing up some huge, huge numbers. And Dr. Mark talks to these people. He talks about their business. So use the assets that we have around. And for those of you that didn't get all of your questions answered, please take advantage of, join our Facebook group. Click the peer-to-peer link. It's on our website underneath the About Us tab, not on the front page. That's my link. And then we have the Facebook for the Institute of Regenerative Education. And then Dr. Chun is actually going to be joining us on the pain side to kind of talk more specific and more direct in some of the intricacies of those practices. We have a couple physicians now that match up to the specialty or type of business people are trying to expand into. So with that, I want to say thank you very much, Dr. Chun and Dr. Martin. I've got to cut it off because I know when Dr. Martin gets going, he loves this stuff. This is what he lives for. So he'll keep going, and I got to, give him a break. I know he's been traveling. He just got back from Mexico, and I know Dr. Chun's got a busy practice tomorrow. So we're going to let them run, but we appreciate all of your time. We appreciate all of your questions. Please reach out to support@platinumbiologics.com if you haven't gotten your links or you need the back office or anything else. But this will conclude this webinar. We are going to have another one next month, so we'll be sending that out. Thank you so much, each and every one of you. Dr. Martin, any last remarks?
No, thank you very kindly, and look forward to seeing you all here in the Facebook group or on a peer-to-peer link.
Thanks,
Have a
everybody.
very blessed day.
Have a wonderful night. Bye-bye.
Thank you.
Bye.
Good night.